Good afternoon and welcome. My name is Nick Davies and I'm a Programme Director here at the Institute for Government. On behalf of the Institute and the Nuffield Trust, thank you very much for joining us for this webinar on the abolition of NHS England. On the 13th of March last year, Keir Starmer announced the abolition of NHS England, the arm's-length body responsible for overseeing, planning, funding and delivering the health service, with its functions to be merged back into the Department of Health and Social Care. Almost a year later, work on the transition is underway, but key questions and decisions are still to be made. So what are the risks and opportunities associated with abolishing NHS England? How much progress has been made to date? What can be learnt from previous structural changes to the NHS and other parts of government? And how can the government get the reform process right? To answer these questions and more, I'm delighted to be joined by Mark Dayan and Sarah Reid from the Nuffield Trust and by my colleague Stuart Hodnott. I'm going to ask our panelists some questions before taking questions from the audience, but please do start submitting your questions now using the Slido Q&A function. And you can also upvote the questions that you think are the best that others have submitted. Okay, let's start with the case for abolishing NHS England. Mark, what have been the main arguments used by the government?
Well, it's a good question. So through the months since the first announcement, the government have come up with really perhaps three different reasons why the abolition of NHS England could achieve something positive for the health service and public policy. And the first of those to be mentioned in the Prime Minister's speech, where Streeting's speech is kicking this whole thing off, was simply that it enables a headcount reduction in the centre of government across the DHSC and NHS England of 50%, and that will deliver savings, and that's part of a wider efficiency drive to which they've been emphasising their commitment at the time. Now, I think we would say that there are a lot of staff held at the centre. A 50% headcount cut genuinely would deliver savings well into the hundreds of millions, potentially over 700 million, as the government have said. But really, that's not necessarily a direct consequence of abolishing NHS England. And to some extent, I think we need to understand what's going on as layering that headcount cut policy on top of this abolition as a single policy about where things are going. And I'm sure Sarah or Stuart in a bit can talk about what we made of the evidence for the extent to which that's an opportunity, the extent to which it has risks. The two other points that the government have mentioned are, so secondly, Wes Streeting in particular has often been the one to speak about this, a narrative that the NHS has, as he says, too many checkers and not enough doers. So too many people, literally, and in too many different teams in Whitehall, in the DHSC, in NHS England, pouring different priorities and instructions and guidance down on the trusts and ICBs across England. And we think as a general problem in the service, can argue about what's caused it, but there's clearly some validity to that, right? Trusts do have more priorities set than they've been able to deliver. They haven't hit all the targets in the NHS constitution basically since they've existed. And I think it's been widely recognised in a lot of literature and studies of the health service that this priority thicket, as our colleagues at the Health Foundation have put it, can mean that it's actually very difficult to focus on anything because you're always meant to be focusing on more than you can do. The last objective that the government have mentioned, which is a bit harder for us really to get much of a handle on because it's almost a moral one, is about democratic accountability, by which I think they really mean making sure that the Secretary of State, the elected link in the chain, is closer to the action and is more in control. Now, it's a bit outside our remit as to whether or not that's a kind of inherent model good to have the elected politician more involved. But I think what we can say, and I've gone on for long enough, so I'm sure we'll come on to that in its own right, is there are advantages and disadvantages to having politicians more closely involved with the hierarchy of the English health service.
Thank you. Thank you, Sarah. Mark set out some genuine problems that do exist in the NHS. How credible do you find the government's case that the abolition of NHS England is going to help to solve some of those?
Yeah, it's a good question. And I think, look, there's certainly, as Mark kind of laid out, an opportunity for some benefit here. I think one of the biggest ones is, and many people we spoke to as part of this work described just how dysfunctional this relationship between the department and NHS England can be. We've heard examples of the spending a lot of time arguing with itself or trying to figuring out what the other half is doing or second guessing one another. There's a sense that large parts of the department are spending a lot of their time monitoring and keeping up with what NHS England is doing, trying to get information off NHS England that only it has access to be able to answer ministerial questions or needs. So for sure, kind of bringing these organizations together, abolishing NHS England, could improve some of those dynamics and eliminate some of these really long-standing tensions that have contributed to this culture of mistrust and blurred accountability that has characterized the health sector, I think, for some time. And there's a hope that in doing that, then sure, there could be the simpler chain of command that Mark described, feeding out into systems, a much more streamlined number of priorities that we're now working towards that come directly from the top. That all, I think there's merit to that argument. When it comes to savings, I think Mark started to touch on this, but I think that's where it seems far from straightforward. A lot of it depends on kind of how the implementation process goes. I think, yes, as I just spoke to, there's lots of duplication across these two bodies. There's scope to kind of really streamline and make this more efficient, but I don't think we should underestimate just how different these organizations are and the skills and expertise that they each have. I mean, there's loads of functions like digital, data, public health, social care, regional oversight that only live in one of those places. So I think this ask, we're having to reduce this headcount by half, means that the Department of Health is not only going to have to work so much more efficiently, but actually change the scope of what it does. So I think for me, there's some big question marks there about how much savings that we'll actually be able to achieve on the other side. And then, of course, that also depends on how long this even takes to get there. And the last thing I'll say, and I know we'll be talking about it a lot as part of this conversation, is that this question of whether or not abolishing NHS England is going to be a net positive or net negative for the system. I mean, so much of that actually really just depends on how the change is going to be handled and how it will be implemented and where we even end up. A lot of the problems we see currently and how the department and NHS England interact with government, they have nothing to do with whether or not NHS England exists. And indeed, lots of the problems and dysfunctions I just spoke to that could get better. It's going to take a lot more than just a structural reorganization to change. I mean, we're talking about real behavior and culture change that's going to need to come alongside this structural reorganization. We know from history that structural reform is rarely the end in itself. So I think some hopes that some of this, that things do get better, but a lot left still unanswered, I would say.
And Stuart, I just wanted to come to you quickly on the savings point. So as Mark said, we're talking at kind of hundreds of millions potentially of savings, which sounds a lot, and certainly would be a lot if it showed up in my bank account. But like, how much is it in the kind of context of NHS spending and in the kind of public service and the state spending more widely?
Yeah, so in terms of NHS spending, the NHS budget is about £200 billion a year. So 700 million is roughly 0.35%. God, I hope my maths is right there, off the top of my head. Yes, I mean, again, a lot in our terms. And in terms of overall government spending, I think the government's total day-to-day RDL spending is about 450 billion pounds per year. So even smaller percentage in that terms. But I think also another point is that, and something we've talked about a lot, is that there has actually been a large increase in spending in the service since 2019. There's been a large increase in number of doctors and nurses. There has been that additional resource for the front line that the government talks about, these cuts being for. And at the same time, there's been a historic decline in performance. So I think this is something that is a gap for me as well. It's like it's a real sort of platitude just to say we're cutting management to fund the front line. I think you've got to be clear about what that money is going to do differently this time compared to over the last 7 years. And I haven't heard that yet from the government.
Mark, coming to you, and we've heard a bit about some of these already, but what do you think are the major risks from this reform?
Yeah, good question. I mean, I think probably the place to start is something that doesn't even really qualify as a risk, but came through very, very strongly in the part of our research that involved building a lot of things the Institute for Government had already done, looking at earlier examples of abolitions in Whitehall and what happens. And I think what we learnt and what you guys learnt in your earlier work is it's a near inevitability that an abolition and a merger like this creates disruption, that it takes people off the day job, people who would have been doing management and planning for reform initiatives and for the running of services are instead doing it for their own organisation. And at the same time, they are competing with one another for future jobs when they're shrinking, as they are, in ways that may not always be productive. And so that is something I think we need to not forget. Even though that's a transitional thing, it's happening during the change. The change is obviously extended across a really long period of time. So in that period, we'd expect a slowdown in the Department of NHS England's capacity. And that might come at quite a difficult time because we're also at a period when the government has really high aspirations around a lot of the digital and the service reform things that have come out of the 10-year plan last year. And when they have many other major policy initiatives still yet to come, like the 10-year workforce plan. So that squeeze on the ability to get things done in the interim, I think, is one big possible downside to consider against the advantages of this abolition. There are two others which came out particularly from our roundtables that we held with people both involved in the process and external experts, both of whom were really great, very insightful. And they're almost they are the flip sides of the possible advantages here. So having politicians more in charge more directly with less of a buffer has potential advantages in that they could clamp down the number of priorities, right? And in all fairness, Wes Streeting has made some moves to do that. Of course, he won't always be there. And the Secretary of State would have the ability to go entirely the other way, short-term priorities, making a promise because you feel under pressure for tomorrow's headlines. These are all behaviors that we've associated with more political control in the past, and this reduces the delay. And people from a health service background will also recognise that there's been a lot of reviews of the NHS that have pointed, as the Francis Review and the Messenger Review did, to some of the negative cultural factors in the health service around a blame culture, even a culture of denial that can come in part from political pressure. And then, of course, the last risk really is the flip side of the possible advantage of saving money on staff salaries, right? There will be fewer people in the combined organisation. And one thing that's been a recurring problem in the health service's recent history is areas that are perceived as not the core of the NHS, not hospitals and not general practice. Areas like public health and workforce planning often get forgotten, often get deprioritised. Things get left undone for many years. And the risk has to be, and this was raised by more than one person at our roundtable in a position to really worry about this, that those areas will be more likely to be forgotten when there aren't as many staff to spread across the range of what government wants the NHS to achieve.
Thanks. Sarah, I wanted to pick up on particularly on the disruption risk that Mark mentioned. And, it's fair to say that lots of people in government were aware of the risk of disruption. Indeed, Wes Streeting was one of them. And he said kind of repeatedly, including just months before the announcement, that he had no plans to scrap NHS England because of all the kind of time and capacity it would take. What do you think changed there?
I mean, I wouldn't profess to know what's going on in kind of the internal political constraints, in the political calculations of that. But I do think, well, clearly the government saw opportunity here. There's a huge, the NHS is under enormous pressure. There's real pressure to kind of have to make things as efficient as possible, save money where we can. But I think something to have in mind, I mean, what's been on mind is kind of how this change has been announced actually, and the fact that it maybe wasn't planned for means that it came about in a way that might have been potentially harmful or undermines the ultimate aims of it. So I think this change was announced kind of in the media before there was a chance to really brief staff. I think not taking the time to really formulate a clear vision and communicate that openly and sensitively as staff does come at a real cost. This is far from the only reform in history that's been announced that way. But we know that, as Mark was saying, in kind of the cost of these big reforms, that leaves many people feeling quite demoralized. It damages trust. It eats into productivity and morale and engagement into the work. And again, we need to be thinking that this is all happening at a time where we're asking so much of staff to be able to deliver the 10-year plan and all the changes within it. And we want people to feel engaged and see the greatest purpose for their work. So I think not kind of rewriting history about, why Wes Streeting ended up where he did, but just the fact that where we did end up where we did and how this was announced, I think is unfortunate to the whole process itself. And we definitely heard from people who've involved in past restructures, just how important it was for senior leaders to to really reach that consensus and clarity about why we're doing this change, why it's happening, getting that plan in place, communicating that in a really open and sensitive way down the chain of command. Leaks are an inherent risk to all of this, but almost accepting that as a given, and that it can even be a positive, and just accepting that as part of managing as well, and to really help people feel assured and engage in the work, and able to focus on their core job. So yeah, I think there's a lot to be said and discussed about kind of why we are where we are and if this could have been gone about differently, I think.
Stuart, given that slightly inauspicious start, how much progress do you think has been made since the announcement?
There's been both a lot and maybe not as much as would be wanted. Some things happened relatively quickly. For example, the strategy teams in both organisations were working together, I think a matter of days or maximum weeks after the announcement. So there were some things that sort of happened instantly. There's also been progress towards that headcount reduction. There's been a voluntary redundancy and exit scheme in DHSC and NHS England, respectively. And I think there's a second one of those coming up in the department. So that sort of asking people if they want to leave, trying to make it so it's not such a brutal process. I think there's also been further merging of teams within the department in NHS England. There's been, they're trying to work out how to get some teams to start working together on policy, on operations. There are line managers across different organisations managing in the department. So I think there is sort of progress. I would say that my impression is that it's also been quite haphazard. I think one person I spoke to described it as utter chaos, which maybe is strong, but they're in the department, I'm not, so they're probably better placed than I am. I think there are some questions about just the practicalities of having a manager that's not in your department, in your organisation, how that works with just things like the IT system, your annual review, that kind of thing. I think is quite difficult. And then there are also a few cultural differences, I think. So some people say that NHS England tends to be much more staff more commonly by people who are operational, come up through the NHS, who have very sort of clear specialties, whereas DHSC tends to be civil servants, obviously, who are maybe more generalists, who work in departments, who have sort of a Whitehall mentality as opposed to NHS mentality. So I think there's like a cultural thing that is makes it difficult to merge as well. And then obviously we've had this week the announcement of the timetable for the rest of the process. So the government aims to have the new department up and running by April 2027. So we have about 14 months in which to complete the rest of this process. There will be the first step that will be announcing the what they called it, I think they're called target operating model in a few months' time, and then consultations after that. Simultaneously, there'll be the process to bill through Parliament, and that is needed to establish or abolish the old NHS England and establish the new department. So we've now got a timeline. I think there's questions about how deliverable that is, but it seems there is progress being made towards that.
And so, Mark, we've got the timeline. What are the key outstanding questions that are still to be addressed in that time?
Well, there are obviously a huge number of specific decisions at the level of individual teams, at the level of where bits of IT go, where responsibilities go, that will be being worked through from now, essentially from the announcement this week, on the timeline that Stuart mentioned. And there'll be a lot of hard work going on inside the Department of NHS England on those. And this is probably the kind of thorough process that you need, although, as I think is touched on, it would have been better to kick it off nearer the start. At a much higher level, one really big decision that's left, I think, is will the new Department of Health be responsible for workforce planning and in particular for medical education and training? So ever since medical education has been brought up to be a national thing, it's always been done at arm's length by Medical Education England, by Health Education England, and lastly by NHS England. And there's a good reason for that I think becomes quite obvious when you look at, for example, the level of tension between recent secretaries of state and the BMA that's led to repeated strikes. You do not necessarily want to mingle national politics and all that goes with it in with the question of who's getting which training place and based on which system. So that's a really big and important decision that will need to be made about a major power and where it goes. And then the ultimate decision in many respects, I think, and the one that will determine whether we're getting more of the opportunities we've spoken about or more of the risks, is what the Secretary of State will actually do with their hands much more firmly on the steering wheel of the NHS, with less resistance to choosing any policy course they want. And in particular, I think two issues come up on that. There is the question of whether they'll really pull back priorities to a realistic level so that we get back to a world where the Secretary of State can tell the NHS to do something and it can actually do it because it isn't already too overcommitted. And Wes Streeting, as I've said, has talked good game on that. But there are other things that have been announced recently, like the National Quality Board, where you can well see the number of things possibly creeping back up again. The other one is how seriously we are taking the 10-year plan's commitment to shift care out of hospital and towards improving people's health. And I think there'll probably be more to say on this as we move through some of the other bits of what we've done. But that's a difficult thing for a Secretary of State to sell to the public and even to wider government, to number 10, the Treasury, who are used to waiting times as the focus. So because this reform really pulls more power towards ministers than they've had in a long time in the NHS, a lot of the ultimate decisions will be ones they are then free to make.
Thank you. And Sarah, some of those questions relate to the level at which decisions or tasks should be made and carried out. What are the principles that should determine that?
Yeah, definitely. I think this is one of the more interesting questions involved in the abolition of NHS England.
Anyway, it's all interesting.
Yeah,
We've got a whole webinar on it.
and so it's how much is this actually a reconcentration of power within the center? How much of it is actually going to end up in devolving things outwards? If nothing else, I really do hope this change leads to a much more intentional and coherent way of thinking about that. So yeah, in our work, the experts we spoke to came up with a set of principles of, how we can be making better decisions about this. I think the NHS is often criticized or held up as an outlier for just how centralized it is. So this is a real chance maybe to think differently about which decisions might make sense to be made elsewhere in the system. So I won't go, we have our report, you can read it with all the principles within it. But I think some of the big things that came to mind were, are there actual genuine economies of scale of doing something just once? Is it something that can actually even be easily standardized? Lots of examples where that might be true, like purchasing or procuring certain goods, setting standards for things like cybersecurity. Probably don't need to have every ICB or NHS Trust figuring that out for themselves, but loads of things where we need to, we're being much more flexible to different local contexts makes a lot of sense. And I could see that coming up for, in the rollout of the 10-year plan when we define what neighborhoods look like and where they should exist. That's something where we just will not be able to have one answer for. Other principles and things that people brought up were things like, where do we even have the skills and capabilities and context to be able to make a good decision? So for something like medicine price negotiations, the answer probably is within government. But for something like, how are you going to work with community organizations in different ways to come up with different standards or care pathways? You could imagine that the answer for that is almost definitely locally. And lastly, I think another important one to have in mind and kind of where we decide where everything should now sit is, what are the public's expectations? Like, what are different stakeholders expect from all of this? And I think for some things, there's probably really little appetite to have loads of variation. I can think of things like waiting time standards. Probably wouldn't want to have a situation where, depending on where you live in the country, there's different expectations for when you'll start your cancer treatment. But for other things like what size and shape GP practices should have, how big they can be, like what the degree of ownership can be. I mean, those are things where there's probably a lot more tolerance for having differences. So I just really hope, if nothing else, after all this, we get to a place where we can just be far more deliberate, intentional, and think differently about how we put some of those different decisions in the system.
Stuart, as part of the paper, we looked at previous examples of where government has made major structural reforms, including in the NHS, but also right across Whitehall. What are the key lessons from those about how to effectively manage a reform process such as this?
Sure. So we looked at two major examples of the paper and then also other ones that fed into the process as well. In the paper, the two we looked at were the Abolition of Public Health England, PHE, in 2020 and 2021. And then the other one was rolling Job Centre Plus, the executive agency for Job Centre Plus, into the DWP in 2011. So there was 5 things that we came up with that we think are particularly important. I think first of all, there needs to be a clear and coherent vision for reform. And as we've discussed quite a lot in this, That wasn't really the case at the beginning of the announcement. I think actually, as a sort of interesting counterpoint, the Lansley reforms, which we think, or most people probably think were not that successful ultimately, but there was a very clear justification and theory of change that fits into the wider reform program of why they established NHS England in the first place. So that's an interesting counterexample. And that was the result of quite a lot of planning and opposition before the Conservatives entered the coalition government. Secondly, communicate the vision clearly and openly at every level. Again, that was not such a strong point of the start of this process. It was a sort of a rushed announcement that came out publicly before speaking internally. I think the approach has changed since then. I think, like the example this week of the announcement, the timeline was much more sensitively discussed and cascaded down through the organisation. It's important to sort of reach a decision at the top and then, I think, quite quickly spread that message downwards. And that's important for maintaining morale. I think in the case of PHE, we found that poor communication eroded engagement quite quickly. And in the case of Job Centre Pluses, they had quite a strongly communicated vision of what that improvement would look like. Next, there needs to be a balance between moving quickly and getting the deep-seated reforms right. I mean, obviously, it's terrible to have a structural reform that takes 4 to 5 years. But at the same time, if you rush this process and you sort of hastily establish different directorates or bring bodies in or out of the department, you might just end up in a worse situation in a few years' time than you are now, or having to redo things. So I think it's important to get that balance right. And again, the timeline now seems quite thought through. At the same time, alongside that, you need to get the basics right, get the IT right, the legal right, the governance right, because if you try and skimp on those now, it just cause more costs in the longer term. I think, again, reform creates uncertainty. The pace is important. People will be constantly wondering about their jobs while this is all up in the air, all these questions are unanswered. So I think it's good to have clarity on that, and to try and do the headcount cuts relatively early to try and get to the point where people understand what their own personal position is and you can move forward with the reforms. I think finally, the last one is establishing a unified culture. So in PHE, they merged the PHE and UK Test and Trace organisation leaderships together to create a UK HSA. That was done relatively quickly. There was a sense of having a shared vision and purpose for that merger. I think that's quite important here. And again, to be fair, they've done that. They've merged some of the high-level teams. The leaders are sitting in the same organisation. They're trying to make that unified culture. I think just very quickly, the final thing I'd say is that it is difficult to find a precedent for this. This is such an enormous reorganisation of two very, very different organisations that it's hard to look at anything in Whitehall, even something like merging FCDO and Difford, or FCO as well as Difford, into the FCDO. So I think this is just a very complex merger with a lot of different moving parts that makes it a little bit without precedent.
And Sarah, as Stuart was talking about the timeline there, and one of the kind of the key elements of the timeline is the need to pass primary legislation, and an NHS bill is due later this year, and it assumes passing and then being implemented relatively quickly. But I think it's fair to say that NHS bills, and the 2012 Act is a very good example of that, they haven't always had an easy ride through Parliament. So what do you think are the kind of the big risks are around the legislation, and what impact could that have on the restructure?
Yeah, I mean, absolutely. I think the biggest risk here is just that bill gets overloaded and overstuffed, and it becomes ever more complicated to get through, and it extends the pain of this change, really. So I think having discipline about what needs legislation to make the change happen, and keeping it very focused and narrow on those means is important here. And I think looking back 2012, I think that's one thing we heard is just that bill got overwhelming in size with loads and loads of things tacked onto it, where I think those looking back would said it'd been much better to try to achieve the elements of the change that we could through non-legislative means. There's lots about abolishing NHS England and recreating the centre of DHSC that doesn't need legislation to get on with and start doing. So I think being very disciplined, but I know those leading the transition don't have entire control over that process. There's a lot that's like out of the hands of those kind of leading this change, but that would be the one big risk there. Yeah, at least from the legislative perspective.
Thank you. And I'm just going to ask one more question before opening up to questions from the audience. And there's lots of questions that we've already received, so I'll try to get through as many of those as we can. Mark, I wanted to ask you, one of the key questions from our paper, and something we've touched on today already, is how critical ministerial behaviour is to the success of this reform. What do you think Wes Streeting and his colleagues need to do to make a success of this?
Yeah. So I think when we get to that end state and the Secretary of State in their department holds all these duties much more directly, there are probably three things that Wes Streeting or his successor will need to do, none of which are easy. The first is about culture. It's about resisting the urge to get out of tricky political situations or generate political capital by blaming managers and underlings close to you for a few reasons. Firstly, that encourages the kind of denialism and even secrecy that was flagged up to be a problem in some earlier NHS scandals. Secondly, it can really put people off from seeking promotion in their NHS career. And in particular, if you're thinking about a job in a difficult hospital, and most of Britain's hospitals that are struggling, that is for a complicated range of reasons to do with the local area and the workforce there, you may be really put off if you think, if I take this on, I'm going to get fired by the Secretary of State in public and it will end my career forever. So restraining yourself on that front is something that politicians will have to learn to do if they're that close to the managerial level of the NHS. The second, I think we've discussed quite a bit already, but it's keeping a lid on the number of priorities. As I've said, Wes Streeting in things like the planning guidance actually has tightened down the number of priorities being handed down to the English NHS. But it does run somewhat against the political grain not to promise more, right? And if you keep doing that, you will end up with a situation where you can't get anything you want because the service is too overloaded. And then just lastly, I think there's the question of managing up. So something we haven't spoken about that much today, but it is an important backdrop to all of this, is that desire to shift care out of hospital to essentially change in the long run to a health department that isn't just about the NHS fixing people when they're ill, but is about keeping people healthy in a more fundamental way. And that's very difficult for a Secretary of State, in part because they have to manage upwards as well. So the Prime Minister is committed to the 18-week waiting time target for planned care as the health mission for this government. The Treasury are very used to renegotiating on this constant cycle of the NHS needing bailouts and expecting more immediate productivity and faster waiting times improvement. So getting off that hook of delivering more hospital care of very particular types as the only thing that the government writ large focuses on is another very difficult task for the Secretary of State, but obviously one that potentially does unlock the idea of having a more strategic health department that is about improving the health of the English population instead of simply trying to keep the NHS chugging along.
You've touched in a few cases there on kind of questions of kind of priorities, accountability, etc. And I think that leads nicely onto one of the questions we've received, which is that if NHS England's functions are absorbed into DHSC, where does practical accountability for controversial service changes actually sit? And how will the system demonstrate that decisions remain open to genuine challenge? Mark, I don't know if you want to come back on that, or Sarah, if you want to come in.
Well, I would just say that is a great question. It's already one that's actually really quite difficult to answer because people might remember that the last NHS bill in 2022 gave the Secretary of State a lot of control over local reorganisations, particularly if almost anybody objected to them. The Secretary of State really is quite close to being on the hook for even quite small changes to hospital all across England. And I think we haven't yet fully had the test case where a local controversy becomes a question that really works its way all the way to the top. But that is already something that can happen and will be even more so once these reforms have come through and there's no extra layer in between the front line and the Secretary of State. So, I mean, what I personally think needs to be looked at part of that is creating more institutions that can act as a filter and a more local place for accountability. Because otherwise you do run that risk of a bottleneck of responsibility in the centre where it can't necessarily be discharged with the care that you'd like.
I'm going to pick up two questions together now, which is both. I think the common theme is about learning from others. In some cases, the past, and in some cases, other countries. So we've got one question from Dr. Graham Wynyard, who's asked, Has any effort been made to investigate, learn from the reasons behind the original drive to set up an arm's length management body for the NHS dating back to the 1980s? Some of us were around then and are bemused by what is happening. And another question we've received, which is, does international experience from countries with similar health systems hold any lessons for how to arrange national leadership for health services? That's a lot of questions, but Sarah, you were nodding, so I might come to you first.
Sure, and I'm probably, given my background, best place to take the international lens to that. So I'll start there at least. Yeah, really interesting question. I think I mentioned earlier that, NHS is often held up as being one of the more centralized health systems in the world. And I think that's true. A lot of people say that's because we're a tax-funded health system, but there are other examples of other health systems that are also tax-funded that have far more devolution and local control in place. So I'm thinking of places like Denmark, Sweden. They're highly decentralized systems. The kind of in those models, the government kind of sets the vision and standards, but it is, full local authorities are really the ones who are driving what services look like, what they're covering, what they're doing, how care is designed. They don't have nearly as many central mandates coming down. But one really key distinction I think that is unique to us versus some of these other countries is that there's a lot more democratic accountability for health services in those countries. So those local those are elected officials in those health councils, like kind of our integrated care board equivalents, who, there's politicians at lower levels of systems that have full ownership for the NHS. I think that looks really different. We have kind of a weird setup where the NHS is kind of the ultimate accountability is at the top with central government. Social care, it's really different. Local authorities have a lot more accountability over how those services are designed and delivered. But the fact that we don't have that inherent local accountability built in, in a democratic way, I think is a real big difference. And I know there's talk about changing that. I know other sectors of government are changing more in that direction. So, but I just think it's really interesting. Like, we are indeed a more centralized health system, but I don't think that's just because we're tax funded.
So I just want to pick up on that because so we had an event last week with Penny Dash, the chair of NHS England, and I put to her this question of kind of centralisation, because that kind of this reform does give the Secretary of State more power. And her argument, she denied that it was a centralisation. Her argument was actually because of the kind of the big headcount cuts that would be happening at the centre, that would kind of free up local areas more to make their own decisions. Like, to what extent is that a credible argument, and to what extent is that a way of kind of combining the democratic accountability via national elected officials versus giving more autonomy to local systems? I can see both Mark and Stuart want to come in here, so if I go to Mark and then Stuart.
Sure, thank you, Nick. Yeah, so I think the first thing I'd say is that is a really interesting point because there's a deep paradox in the government's reforms taken as a whole. The headcount cut that we've been discussing today means there are fewer people in the centre. So in that sense, it could be seen as decentralising. But many of the wider changes that we're seeing, changes to ICBs, the new existence of regions as very much outposts of the centre, are centralising power. So, there's a positive story you could tell about that, which is that there were too many people relative to the number of powers, and that led to too many priorities and confusion and duplication, and we're cutting it back and it makes sense. But there's also a real risk, which is that you're bringing all these powers in with fewer and fewer people to handle them, and the kind of bottlenecks and the struggle of the centre of government to cope that people like Sam Friedman have written about so often becomes more and more of an issue. And I think it's worth saying, just calling back to your other question as well about lessons from the past. I mean, there have been so many different configurations of the centre of the NHS, with the chief executive and the permanent secretary of the department being the same person or different people, an NHS executive, NHS England. Some of the most powerful institutions, I think, have been ones that aren't written down. One that we heard about was the idea of a gateway that controlled the number of instructions that could be sent out to the service. I think that's an example of how you could yet use this reform to do things that genuinely do promote autonomy and decentralization, if that's the direction we end up going in.
Stuart.
Just to build on Mark's point a little bit, the first part of his So yeah, we haven't really spoken much about the Integrated Care Board ICB cuts that have been run concurrently. I think on to come back to the original question about Penny Dash's point that it's a decentralization because you're removing layers and you're taking away the sort of the heavy hand at the centre. I think to me, yes, I think there was probably arguably too many people at the centre of the NHS. But cutting that capacity out of ICBs, I think is also a bit of a neutering force for sort of devolved decision making and policy making in the NHS. I think it'd be more credible to say we really believe in our ICBs as the sort of the policy leads in a certain area. We're going to give them the capability and resource they need to succeed. But I think neutering or sort of cutting them at the same time makes it much harder to achieve that, and particularly also the aggregation of ICBs into larger geographies. Again, we've gone from 106 CCGs to 42 ICBs to now 26 ICBs. It's getting ever larger geographies. It makes it harder to really have a sort of good detailed view of what is going on in a local area that is sort of required for very good devolved policy making, I think. So yeah, that's the bit that I didn't really understand from Penny's argument. But I would agree with her probably that too many in the centre.
Sarah, come to you next.
Yeah, if I could just have one final point on that. I think I completely agree with everything Stuart and Mark are saying. But I do think there's an interesting thing, like I think as policymakers we're guilty of like trying to get that there's one answer for what the optimal level of centralization and decentralization is in any system. And it's interesting doing so much international work because I just see the similar swings in other health systems of re-centralizing and decentralizing. I always think it's going to answer the problems, and it like there's just trade-offs to both, and that's why I think we try to come up with a set of principles in our report because it's saying like there actually isn't one answer. There's some things that can be more decentralized for good reason, and other things that can't, and don't try to just think of it as a whole. And it just, I think it's something that I see governments spending a lot of time in reforms trying to get right. And it's interesting to see everyone kind of just keeps oscillating back and forth between one and the other.
And just to kind of finish on this kind of structural change and kind of centralization point, Stuart, is the kind of this potential centralization, is this reflective of a wider trend that of seen in terms of this government's reform efforts across public services?
Yeah, so we've at the Institute been spending a bit of time this week just internally discussing the trend that seems to be emerging across different public services of announcing quite large structural reforms. We've obviously had it in local government with the unitarisation of district councils, the NHS. We have had it now in the police, as the one that was announced this week in the white paper, and also in criminal courts as well, and also some others in children's social care. So I think there's an interesting pattern of government's revealed preference for reforms seeming to be structural, seeming to be changing the way that services are organised. In some cases, I think it's more justified than others. I think we're pretty positive about the police reforms. And also at the same time, tending to drag power upwards to either larger geographies or into the hands of ministers. So the police white paper puts a lot of power in the hands of the Home Secretary, a lot more power in the hands of the Home Secretary. So I think there is something interesting with this government where they're preaching their reform principles of devolution, integration, and prevention, while at the same time falling back on sort of more typical mechanisms of structural reform and concentrating power in the hands of ministers.
Thank you. Sarah, I want to come to you on this one. I think picking up on some of the headcount discussion we've been having, they've said it's been hard to get a clear articulation or specific examples of where there's been duplication between NHS England and DHSC. Can you provide any more specific examples of where there has been that duplication?
Yeah, sure, of course. And I think part of this and why we might not have the best answer to it yet is because like the center hasn't gone through that mapping exercise yet, really looking at what NHS England does, the unique skills and expertise it has, and what the department has, and really mapping that out clearly and understanding. I don't think we fully know the answer to it, but I think when we've done this work, some of the examples we came across are more around kind of the policy and strategy functions. I think there are a lot of teams kind of formulating visions and strategies on certain areas of care that exist in both places where there might be more overlap, but there's there's equally, if not more, functions that are really distinct and do not live in both places. And I gave a few examples of that, particularly around kind of like digital and data and social care and public health. And I don't like I think these organizations, the people who work within them have really different skills and expertise, all of which are hugely important. So the question is how do we get the most optimal blend of those skills and expertise given whatever the role of DHSC will be moving forward?
And actually, just picking up on that kind of skills point, someone said, I think about something you said earlier. They said counterpoint to Sarah's point that DHSC are hunting down what NHS England is doing is that there simply has not been enough subject matter expertise on the part of the civil service. Are you concerned about that getting lost?
I can come in quickly. I'm sure Stuart and Mark will have views, but I think, yeah, that when we were talking to people close to this change about the risks, that was something that definitely came up as thus, again, the different skill sets that these bodies have. And I think the civil service, they have very unique and specific skills about how to work within government that is hugely valuable and important. But NHS England has essential operational skills and know really the ins and outs of the NHS. It's not all that content and that operational expertise is not always present within the Department of Health. So, and both are essential to have a functioning centre. So I think how we get the optimal balance of that is again one of the biggest risks, biggest questions involved in this change.
Stuart.
So just on this point as well, I talked to colleagues in our civil service team about this process of voluntary redundancy and voluntary exit, and is there a risk that doing them before you've worked out the structure of the department could lead to losing people who you suddenly realize in 8-9 months time you actually really need to sort of match the capability of what you want the department to do? I think that is a risk. I think their view on this, having thought about this much more than I have, is that voluntary redundancy schemes in general are just a really bad way of maintaining and keeping talent within the civil service. That often it creates a demoralizing atmosphere in which some people who are high performers sort of say, okay, well, I've had enough, I'm going to leave. There's no process of keeping those people regardless of what you want to do at any point in the future. But I think I would agree with the point about the very specific skills in NHS England that Sarah and the questioner mentioned.
Mark, going on to a slightly different tack, someone has asked, is pandemic preparedness work across the health service, e.g. planning for ICU surge capacity, likely to be more effective? Sorry, that my cat has joined me, so apologies if you see a tail flipping in front of my screen. Is that likely to be more effective if there's a closer relationship with existing DHSC pandemic preparedness teams?
There is the potential for that, and I think it touches on something wider, which is you might hope that the merging of NHS England into the DHSC leads to better coordination between the NHS bits of that remit and all the other bits, public health, whether it's infectious diseases, whether it's preparedness, planning with other parts of government, etc. That's definitely one of the possible advantages that we did here, flagged up by people who should be in a position to know. And there's a lot of other things that go into the adequacy of pandemic planning, as we found out so tragically. But that could be a cause for optimism there. On the other hand, and again, I think the fact that we're coming back to this so often really tells us something about what some of the complicating factors in this reform are. The size of the headcount cut will exert a pressure on all of that. So you really have these two forces pushing against each other that we heard quite a lot about. On the one hand, you're bringing powers together, and that should enable the NHS to work better with other bits of health, social care, public health. But on the other hand, you're really squeezing down the number of people who are actually there to do it, and that will create some very, very hard decisions.
So there's another question here about kind of cuts, and they've said, with the abolition of the National Guardian's Office, what mechanism will exist to protect whistleblowers or hold NHS individual trusts to account? Would anyone like to come in on that? Sarah.
It's a really important question, but I'll start by saying I don't have the answer to it, but I want to use it as an illustration of like these are the questions that those involved in the change need to be thinking about. There's so many important functions that might not have the most natural home now. And we came across a few in doing our report. I think that just speaks to kind of the complexity of this change, of this, this isn't just merging two typical organizations. There's loads of things that are unique to health that make it really complex. So yeah, the extent that we can learn from other examples from history is limited in that just that there's so many things that are very specific to this transition that we haven't encountered necessarily before. And I think this is one example of there's going to be a long list of things that we need to be thinking critically about and where it now lives. And yeah, so I think this is the hard work that needs to be happening now. Sorry to give a less than helpful response to that.
Stuart.
Yeah, I don't have any coherent thoughts about the Guardian office for about whistleblowing specifically, but of all these very detailed little decisions. I was talking to a colleague about the legislative process, who knows much more about Parliament than I do. And their point was that this is something that actually could stretch the process out beyond the point at which there is royal assent for the act when it eventually passes, is the sort of the regulatory statutory guidance that's needed after it gains royal assent could stretch us out longer. As an example, they raised the assisted dying bill, which has a 3-year period after sort of laid out in which they expect to have guidance and amendments or regulation added to sort of make sure that everything's working well. I think that could be the case here as well, potentially. It's just the sheer number of things that have to happen and consideration you have to have and different bits of guidance you have to issue might stretch this process out actually longer than just the abolition of NHS England.
Another question here, and I suspect all three of you might have thoughts on this, which is, how can health be reformed if social care isn't reformed? And how can health and care locally be improved if there's not a single view of the workforce? Oh, Mark, you're first to get your hand up there, so you can come in first, quickly followed by Stuart.
I mean, the point on social care is an excellent one. We shouldn't lose sight of the fact that social care is something different to healthcare. It's got its own objectives, which are about people's ongoing well-being and being able to live their lives. It's not about fixing and curing people in the same way as the NHS. But the length of time over which we've had delays to any kind of reform of adult social care have left us with a really threadbare and quite unfair system in England. And I think you do start seeing quite concrete terms how this can be a problem for the NHS. One of the things that we've seen recently that the Nuffield Trust flagged up in our research is spending on continuing healthcare, which is when the NHS has to cover social care for people with an ongoing health need. That's really been going up quite markedly, and not because it's treating more people, it's costing more. And that probably tells you something about how the fact that essentially we don't really have a functioning social care system that's providing insurance for most people in England can just leave those costs to fall really quite literally on the NHS. And of course, a big question following this reform, and another thing to watch for, is will there be more attention on social care when it's next to the NHS, or will the NHS crowd out other things even harder as a job for the Secretary of State now that he's fully in charge of it?
That actually leads to another question, Stuart. You might be able to answer this and weave in your thoughts on social care as well, which is from David Winskill, patient voice advocate. He said staff worry about the order in which things are being done and who will be responsible for what, all against trying to achieve the 3 shifts in the 10-year plan and indeed all the other things that DHSE is responsible for. How will the new DHSE be able to keep the lights on?
I think a very good point as well, just to come back to the social care bit. I mean, I agree with everything Mark said. I mean, a question that's been raised for me is this is the Department for Health and Social Care. And we kind of forget that when we talk about these headcount cuts. We're talking about headcount cuts across the whole of NHS England and Department of Health and Social Care. I mean, the social care element of DHSE could lose out just because it's sort of caught up in this wider headcount target, which so I think we haven't really discussed that too much. So there's an issue about capability within the department on social care. I completely agree about the coherence of having structural reforms in NHS and this sort of rickety system in social care. I would love to know how much discussion there is going on between the transformation team for the abolition and the Casey Commission about what recommendations they're coming to. I mean, maybe they're not even at the point yet of being able to make those kind of recommendations, but I think it's a really good point. I don't understand how you can really properly reform either um, without knowing what the final form of the other one will look like. It feels completely incoherent to me. On the point about the other priorities, this is something that we have raised repeatedly as being a massive risk of this reorganisation. Is there is a huge amount of other things happening in the NHS. The shift to the community, the shift to prevention, those are enormous changes. And the staff who are supposed to be delivering them are currently either fighting for their jobs in ICBs or wondering what, if they're going to have a job in a few months' time, or just trying to work out what team they're going to be in. So I think, this is a very limited parliamentary term. There's 5 years when they started. There's now heading towards 3. By the time this process finished, I think 2 years left of this parliament. I think it'll be very hard within the following 2 years to make a lot of progress towards those very complex policy issues. And I think that you can do things simultaneously, but attention is a finite resource, and a lot of it is being eaten up by doing this reorganisation.
We've talked a few times about the risk of kind of talented and experienced people leaving, and someone's asked what can be done to mitigate that risk and the kind of skills gap emerging in the new department. Would anyone like to come in on that, Stuart?
I can understand. I think part of it is about the clear communication, is about trying to maintain morale for the staff that are already there, making sure that you're not hearing about future job losses from the HSJ, making it feel like there is a joint project, and having that top-down leadership and communication, I think is important. I think also maybe a more pragmatic point, one that our civil service colleagues here would make, is just knowing who your high performers are and trying hard to make sure you stop them from going. And that's where the point about the voluntary redundancy and exit schemes comes in, is if you're just doing a sort of rushed blanket scheme to get anyone out the door possible, there's no way of defending those high performers, I don't think.
Mark.
I agree with all that. I think just to offer an actually slightly more positive take, one of the strategies that we heard about from previous reforms that had worked relatively well is you start at the top level with your directors general or similar. You work down into their teams and what they each do, and then you work out who needs to stay and who needs to go based on that. And broadly, through a lot of delays and through a process that still has many risks, that is the approach that's been outlined this week and that started last year by appointing joint directors general. So that sort of cascade down to trying to secure things in the team where they're needed is going on. It's just going to be incredibly challenging because of the scale of the headcount cut that was committed to up front without any real assessment of whether that was necessarily the right level.
And Sarah, I think given time, probably the final word.
Oh, well, pressure. Well, I hate to be bringing us back to a negative space then, but I think one area where I'm really keeping an eye on this risk in this conversation is around data and digital. I think it was really interesting when we did this work. We heard often that the skills that the government has the hardest time holding on to are around kind of digital transformation and tech. And if you look at the 10-year plan and the entire mission within it and how much we want to be rolling out and scaling all these innovations at the same time of doing this headcount reduction and thinking about the skills we need, I'm really worried about that. And we also have to remember we are making this change on top of other changes that have just been happening to bring more of that kind of central digital and data function within NHS England. And I think there's a risk now that we devolve some of that, we cut it, we don't give it the energy and expertise that it needs. And then, as with many things, what we need to kind of really get tech right in the NHS to live out and deliver the 10-year plan is just greatly reduced. So yeah, I think in terms of things to watch and be worried about, this is something that's on my mind.
Thank you. Well, on that note, I'm going to bring this discussion to an end. Thank you very much to our 3 fantastic panelists. For more information, please do check out the report, which has the great title, I wish I could claim credit for it, of Abolished to Perfection, ? Building a Better Centre for the NHS. And that is available both on the IFG and the Nuffield Trust websites. If you're joining us from government and would like to discuss any of these issues further, then please do get in touch. Until then, thank you very much for tuning in, and goodbye.